It's my pleasure now to introduce Christine Walker and Chris Peterson, also from Australia, to give their presentation on the universal health care and COVID-19 as view from systems and complexity. I hand it over to you.
Thank you.
Thank you, Joachim.
Do you want me to share the PowerPoint now?
That probably might be easiest for you to go through the presentation. Yes.
Can people see that?
Yes.
Oh, good.
Yes. Could we go to the next slide?
Yeah, sure. This one?
Yeah. So this is on the universal healthcare and COVID-19, a view of systems and complexity. We're two sociologists from Australia. Please don't hold that against us. My name is Chris Peterson. I'm a health sociologist. I work in the Department of Social Inquiry at La Trobe University, and I've worked in the National Centre for Epidemiology and Population Health at the Australian National University, and in general practice and education at the University of Melbourne. And I'll let Christine introduce herself.
Thanks, Chris. Yes, I'm a health sociologist too, and my particular interest has been around health policy, and particularly health policies relating to chronic illnesses. And I also have a long-standing concern around social inequalities and the effects of inequality on people's health.
Next slide. The one before that.
Okay, yep.
Yeah. Now, our work for today is theoretical and issues-based. It's not based on empirical research. And it was based on a reflection of Sternberg and Martin's analysis of universal healthcare and primary healthcare. They present a systems approach and complexity theory approach and show how it can inform universal healthcare and primary healthcare. They do this by critically evaluating how the WHO links both universal healthcare and primary healthcare. We propose that the political economy refers to a socio-political and economic system that underscores universal healthcare and affects the organisation and delivery of primary healthcare. This system can be understood as a complex set of arrangements and relationships that need to acknowledge the political dimensions of healthcare. So basically, and we'll go into a little more explanation of this, the political economy means that both the political and the economic issues influencing healthcare are fully understood. We propose that much can be gained by examining the effects of COVID-19 on the political economy of universal healthcare. A little later on, we'll draw some attention to a very recent editorial by The Lancet on the UK system and universal healthcare. And they basically raise a question. They have universal healthcare, but look at the terrible outcome of COVID-19 in terms of infection rates and deaths. So we'll discuss that a little later on. Now, universal health coverage means that all people have access to health services they need, when and where they need them, without financial hardship. It includes a full range of essential health services, from health promotion to prevention, treatment, rehabilitation, and palliative care. So universal health care is also called universal health coverage. Universal coverage, or universal care, is a healthcare system where all residents of a particular country or region are assured access to health care. Christine, can we have the next slide?
Yes, I just want to add to that universal health coverage or care is understood quite differently in different countries, and so particularly the UK, Australia, and the US are good examples of how variable universal health care can be.
Yeah, thanks, Christine. Back to the previous slide. Thanks. Now, the political economy, expanding on that concept, refers to a socio-political economic system that underscores universal health care and affects the organisation and delivery of primary health care. It acknowledges the political dimensions of healthcare. Now, the concept political economy began in the 18th century with the writings of Adam Smith. It has different meanings, but incorporates economic and political analysis of modes of activities and governance. The term political economy of health has been in use for a number of decades. Understanding the political economy was crucial in realising how universal health care operates. It is a perspective on health policy which attempts to look at economic, social, political, historical, and cultural factors influencing health. And the WHO has presented in a number of forums on the relationship between political economy and health financing. And it's a process to help policymakers develop more effective approaches to navigate political challenges that arise when introducing policy changes. The WHO has developed an approach to analysing these systems to support strategies in the progress to universal health care. And they recommend any country or nation or region looking to introduce universal health care must account for the political economy to fully understand the forces and the positions of different stakeholders. Yeah. So the next, Christine.
Yeah, and I think that part of the complexity about all of this issue around political economy of healthcare relates to the fact that universal health coverage can change depending on who's actually in government, and that makes it very complex for both the consumers and the deliverers of healthcare.
Yeah. COVID-19 pandemic revealed the inequality inherently reproduced by neoliberal economies. Neoliberalism is a policy of maximising freedom of markets with little government control and spending and low levels of taxation. Currently, WHO reports there are over 250 million people who've been infected by the virus, and an estimated more than 5 million have died. Christine, you might want to comment on that.
Yeah, the other issue around it, the neoliberal policies, is that neoliberalism has undermined a lot of social security measures, and as we understand it, social security is a conduit to maintaining health. For example, being able to afford food, good housing, and having some kind of security for income are things that really help to maintain health. And that is undermined.
Yeah, morbidity and mortality in the pandemic have been worse for migrants, Black people, Indigenous people, and those who've been discriminated against or marginalised. Disease risk is more in precarious work and for groups such as mobile workers and so on. The consequence of COVID-19 has led to the poor and marginalised suffering disproportionately. Countries having insufficient vaccines and medicines will have the least bargaining bases. Next slide, Christine. Now, Vicente Navarro argues that pursuing neoliberal policies during the pandemic would at best be foolhardy. He maintains one of the key public policies carried out by governments with neoliberal tendencies have been the mass privatisation of public services, which is so vital for the well-being of populations. The free market approach will not achieve universal health care. Social security measures, as Christine mentioned, are important to maintaining people's health by giving them access to health services, food, housing, and employment. Countries are finding that health spending is not an optional. Universal health care has demonstrated through the pandemic that it's essential to move from basically private funded to compulsory public funding. For universal healthcare, it requires political will, and it's also essentially a political process.
Yeah, I'd also add that Navarro's point of view was reinforced by the WHO, that they pointed out that health financing was important to strengthen all the frontline services during COVID, and that countries needed to improve their universal health coverage, and they were arguing that public financial management was the backbone of actually dealing with COVID.
Yeah, Christine, the next slide.
Yep.
Yeah. Another facet of neoliberalism that creates and preserves inequity is it affects access to healthcare generally by decreasing social services. Christine, would you like to comment further on particularly, say, what Australia did during the early stages?
Yes, well, in fact, Australia during the pandemic, or at least the first lot of the pandemic, actually improved their social services, and particularly with providing better funding for people who were unemployed because of the pandemic. I think that was really the main value of the Australian government's program at the time.
Yeah. Could we skip the next slide and go to the following one?
This one or?
The next one, yeah.
Okay.
Universal health reform has often been brought out of a crisis. It's therefore possible that, like other crises before it, the pandemic could catalyse universal healthcare reforms should global leaders choose to harness the opportunity. For most countries, moving to universal health care has come from disruption to the status quo, mostly from moves towards democracy or uneven status of the state. Many countries during the pandemic have been optimising opportunities to expand universal health care, such as Cyprus and Finland. This comes from the Lancet, British Medical Journal, Bump and co-workers. The regressive distribution of the virus and competition for supplies and vaccines indicates that the political economy of COVID-19 is the political economy of extraction, following long-standing patterns of exploitation. Extractive relationships are fundamentally unequal and are the opposite of the collaborative fairness embodied in the general ideals and ethics of public health and in the specific calls for solidarity and cooperation made by the World Health Organization. So what Bump and co-workers, they're basically saying that the old colonial divisions over hundreds of years have been accentuated and maintained through the pandemic, and they should be changed, but they're not. They're the basis of inequality. Christine, do you want to comment?
I was just thinking that one of the things that have come out, emerged from the disruption of COVID has been a whole new argument for the value of universal basic income. And not only does that improve social security measures, but it's also been seen as being able to underpin the economy of countries, and it is still an ongoing debate around that. But I think that we might see social security measures strengthened, and something of a return to Keynesian political economy in the future.
Just a brief comment, and we're getting to the point of winding up. A recent editorial from the Lancet, and it's only 2 or 3 months old, I think, said that the UK has universal health care, but if you look at the outcomes of the pandemic in terms of infections and death rates, it's absolutely terrible. So what is going on? Why isn't universal health care working there? And they said, well, the focus of the universal health care is on dealing with acute conditions, and rather than prevention. And that's where their universal health care needs to change. And Christine, did you have any comment about that?
No, only to say that it's a good example of how politics plays a strong role in the success of universal health coverage or otherwise.
Yeah, what the editorial says was that some of the problems, more deep-seated problems that the pandemic has come up with, is that the nature of neoliberalism, that there are long-standing divisions and inequalities in the community, and unless the government is prepared to deal with those, they won't have a fully functioning and fully effective universal healthcare system.
Mm.
Yeah.
We've basically covered that, haven't we?
We have. We need to look at the limitation of neoliberal policies, especially in relation to social service. And those policies create an inability to be healthy. Thank you, Joachim.
Thank you, Christine and Chris. I think that was highly interesting in terms of the system driver. The policies and politics are a crucial part of the function of the system, and a system that focuses on acute illness, as your final comment has pointed out, is just only capable of dealing with acute illnesses. And I've said it often, I say it here again, we don't have a health system. We have a disease management system, or taking up your point, we have an acute disease management system, not even one that caters for chronic disease, and even less so with frailty, as Carmel had discussed earlier. With that, I open up the floor. Raise your hand. There's a button to raise your hand. Carmel, you seem to have your hand up.
I'm just touching my screen. But actually, thank you so much for that presentation. It really, in a way, is really complementary to what I presented. What the data shows is this, sure, the management of acute problems is really important, but it's assumed in those acute problems are all the social determinants of health, aging processes, social support, income, locus of control. All those things are actually influencing the use of acute healthcare. And in a way, the acute healthcare system then created a pejorative view of these people that are using the acute care system for so-called less important medical problems. So it's a double-edged sword. That one is that we're not addressing them in the community, because the community still, despite all the talk, is the weak link in healthcare. All the money and resources go to the emergency department with these wonderful machines, to the high-tech palaces, is still there. And that's the problem with universal healthcare. That's what they roll out when they roll out universal healthcare, rather than really working on the community and community development, community determinants, support in multifactorial ways for people with less advantage. So it's a beautiful analysis. Thank you so much.
Yeah, and it's promoted probably most strongly by the Lancet, a number of articles in the Lancet that are promoting that point of view, and some in the British Medical Journal. So there's a clustering of discontent there in those journals.
And it's
emerging. Good to see.
Yeah, and it's emerging from the data. Sorry, so I would like to open up to the data scientists here to, to join in with this, to help us make the stronger case.
Yeah.
Okay, that with that, amongst you who are data scientists and also who work more in the social and political sphere, any comments from you, please? Don't be so shy. Otherwise, I call out your name.
Come on, Richard Young.
I think there will be changes as we come out of the main thrust of the pandemic. But the thing that keeps coming up is that social and political policies that foster inequality are always going to be extremely costly for the healthcare system to respond to. And as you said, Joachim, it needs to be focused, the healthcare system, on prevention, promotion, that kind of thing, to contain those issues.
It's almost a form of cost shifting from a social security system to the I'll call it the disease management system, which is quite problematical, and it's actually very costly. But as I said, the cost has shifted over.
All right, Carmel, why do you keep picking on me? You're yoking.
You got broad
3
shoulders
points.
there.
No, I'll tell you what, I'll do a contrarian view. I think the health systems ought to be given a little slack here. I think the tension is any complex system that really thrives and stays stable and resilient over a long period of time has slack in it, right? It's not a tightly organized and precise system like building a Toyota. It's got room to ebb and flow, and so that leads to a certain amount of moment-to-moment inefficiency. Not that the U.S. system is efficient by any stretch of the imagination, but the point is, I just think a lot of people think that when this huge external force acted on the whole system, that it should have just, I don't know, just kept going like nothing happened. And I just don't think that's a realistic expectation. And that I think around all the world, there will always be this tension of the political financial pressure to keep systems within budgets, which is going to push it towards this sort of very tight organized, no slack, no room to wiggle kind of pressures. But then when the external force acts, then it kind of melts down and the system collapses a bit. But your alternative is to keep some slack in the system. That means year after year, it's probably going to cost just a little more than you wish. And so to me, that's one of the tensions I don't see people talking about a lot.
Anyone else?
Oh,
Yeah,
can I
go ahead.
respond?
Good.
Could I respond? So, Richard, does that mean that your view on outliers is that, in a way, the emergency department is a bit of a safety net, and it's okay to have people presenting there in crisis when all the other systems are failing, and there should be some slack in that? Is that what you're meaning?
I meant even broader than the emergency department. I mean, of course, the U.S., our primary care system is so horribly unsupported. You know, the family docs were like a big afterthought. Just watching the policymakers like try to roll out the vaccines and the testing and all that. You know, they, like, all the vaccines went out to the big chain pharmacies before they ever got to family docs, unless the family doc really made a big effort to do it. I guess I'm talking even broader, a sense of just I mean, certainly in the US, that's exactly what the ER functions as, and it's not the best use of resources, but at least there, that microsystem is people in the hall, increased times, the other realities of having this all of a sudden increased demand hit their doors. But the US certainly was no exemplar in how to handle all this mess.
Thanks, Richard. I hand over to Francesco.
Yes, thanks, Joachim, and thanks for this presentation. I would like to make just a brief comment, because you have correctly mentioned that universal healthcare is not the same among different countries. And I can say that also within the same countries, there can be so many differences. For instance, in Italy, the worst situation was in Lombardia, and they have probably the best hospitals for disease management, for high specializations, but they have poor community services. And this is an excellent example of what you are saying, and what also other comments have expressed before.
I think that's the same as in Australia, because and possibly the US too, because with the various states in Australia, health can be managed quite differently,
Yes.
and I'm just trying to think of the US and the variations between the various states over there. Somebody else might like to comment.
Someone else, before we have to bring it to a close?
Ingrid here, just something thinking about is places like Wilcannia, which is an largely Indigenous community in remote Australia, New South Wales. I think they were crying out for community support and services, and it was probably when they were in absolute crisis with COVID hitting their community that whatever the health system came and brought its solution to that
well,
community.
I think to continue on from that, if you look at Western Sydney, it was community leaders, largely GPs, who suddenly got the vaccination rate up to close to 100% for their communities, because they were engaging at the right level. And in the end, interventions are based on trust. The governments at large, and that has to do with political economy and way of looking at things, are not trusted anymore, which is really a dangerous situation that will bring down societies, if you look at it in historical terms. Okay, thank you very much to both of you.
Thank you.
And when in the later sessions we come back to these issues, I'm sure.
Sorry,
David.
I joined late. My apologies. So I missed some of the beginning of the conversation, but on the bit of the conversation I've heard, I kind of was very minded of like David Harvey's work between urban centres and organisation and systems and rural kind of systems and isolations and the inequalities and different structures that you need. And of course, the kind of some of the kind of like recent books around from even when you think of kind of human-gatherer societies of the hunter-gatherers, where the narrative has often been that they are more egalitarian, and as societies got more complex, they got more hierarchical and they got more unequal. But the actual evidence, the data evidence, from new research is pointing much more to the fact that they were not, you know, particularly egalitarian either, you know. So I think in terms of the kind of complexities, particularly kind of in COVID in the UK, obviously, we'd kind of seen inequalities in terms of even some government advice like stay at home for people who are in vulnerable work situations, in low pay, where they have to pay the rent, etc., etc. So certain options and that people have relate to the resources and wealth they have. So there is always going to be inequality as a result of income and your needs for survival and what you need to do today to put food on your table. And so there are inherent inequalities kind of within the system, within our societies. And I totally agree with the comments about the neoliberal economic kind of like systems, because that is based on the idea of, you know, if everyone operates in their own self-interest in the market without regulation, the market will always find its kind of correct level. You know, I know that's a bit sort of more classic of, you know, Adams and Ricardo kind of thinking, but, you know, with the later neoliberals, there was that deregulation that attacked public institutions and moved those things that did support societies and make things a little bit more equal. And they've been under attack in terms of public services or the privatization of services across the Western world. And if we're talking about a Western world perspective, we're not even beginning to think about the catastrophe in the developing world. And there's a catastrophe in kind of healthcare services, but there's a catastrophe in climate impacts related to climate change, you know, and it's easy to feel overwhelmed with the kind of hopelessness because these interconnected things are so complex. But I do absolutely fundamentally believe, you know, the ideas that come out of complex systems, science and thinking, and you know,